Henderson. I'm a board certified orthopedic surgeon. I work at Gotham City Orthopedics and I specialize in the most minimally invasive hip replacement in the world. It's the Othello procedure. It is a direct anterior hip replacement. I'm sure someone here has arthritis or you guys wouldn't be sitting here in front of me. And I can talk you through your options for hip replacement surgery if you need it. I can also talk about knee replacement. I'm also a knee replacement specialist. And we can talk about sports injuries as well, because that's what I heard that the talk was about. But I'll get right into hip replacement options, and what we're talking about today is the Othello procedure. So hip osteoarthritis. What is hip osteoarthritis? It's basically a disease affecting the articular cartilage or the hyaline cartilage covering your joint. When you're born, your cartilage is super smooth, about 100 times smoother than glass. As you age, or through disease, your cartilage wears down like the treads on the bottom of your sneaker or the treads on the bottom of your tire. So if you look at the pictures that I have here, the cartilage on the left is white, it's very healthy appearing, it's super slick, and there's cartilage on each side of the joint, on the ball and the socket side. If you have an arthritic joint, your cartilage begins to get cobblestone, it starts to wear away. There's no way to put that cartilage back on your joint. People will tell you who sell OsteoBiFlex or these other drugs that they can put cartilage back on and they can regrow cartilage. No one has figured that out yet. I wish I had, but I wouldn't be standing here before you if I did. That is the look of an arthritic joint. So why does arthritis of the joint occur? You can have a systemic disease like rheumatoid arthritis or gouty arthritis. You can get a joint infection which basically breaks down the cartilage of your joint very quickly, actually in less than 24 hours. Genetics. Everybody's born with different quality cartilage. Some people get the Mercedes-Benz cartilage that lasts for 100 years. Other people get the Yugo cartilage that lasts for, wears out in their 30s. Most of us end up with like Chrysler Sebring cartilage, and it lasts about 60 years and it starts to wear. Age, just like I said before, your cartilage wears out just like the treads in your tire or the bottom of your shoe. Your cartilage will not last forever. We're living longer and longer. That doesn't mean our cartilage will last longer and longer. So if everybody lives to 150, everyone will have arthritis. Weight. The example I'll use, if you take a tire off a Volkswagen and put it on a 18-wheel truck, that tire is not going to last very long. Okay? Not everybody's at their ideal body weight, including me. And so if I'm meant to be 150 pounds and I'm walking around with 200 pounds, I'm going to wear out my joint faster than I would if I was at my ideal body weight. Previous injury, if you have a fracture of the acetabulum or the femoral neck or the femoral head, all bets are off, because once you damage that cartilage, it's not going to repair itself very well. So here's what I see in the office. So on the left, I see God bless you. God bless you. You see a normal joint space, and you see kind of the bone of the hip here and the acetabulum here, and you see a space in between. The reason you see that space is because cartilage is see-through on X-ray, and that's what we like to see. That's a healthy appearing hip joint. If you go to the right side of the picture, you see the narrow joint space. That means the cartilage is worn away. And in some cases, you can actually see bone nearing and touching bone. The other thing you see in this picture is you see bone spurs. That's the bone's response to injury or irritation. Bone's a very simple organ. The only thing it can do is make more bone. You break it, it makes more bone. You infect it, it makes more bone. You inflame it, it makes more bone, and that's where you see those bone spurs there. So, if you have arthritis of the hip, there's several things you can do. You can limit your activities. I never like to tell my patients to do this. I want people to enjoy their lives and do whatever they like to do, and that's what I'm here for, to get you back to that. You can use a cane. I talked to my father about this. It's the hardest thing to get somebody to do is to use a cane. Nobody wants to start using a cane. So it's not something that's very sexy. Everybody wants to walk under their own power, but it can be a temporizing solution. Weight loss. Easiest thing to say, hardest thing to do. Okay? If you have been heavy all your life and you have hip pain or hip arthritis and I tell you to lose 100 pounds to feel better, that doesn't happen very often. And when we get into the more invasive things, you can try a cortisone injection into the hip joint. I'm rethinking this right now. There have been some recent studies coming out that show that if you do cortisone injection to the hip joint, later on your chance of hip infection after total hip replacement can be slightly increased. That is still being teased out in the literature right now. But I am a bit more wary. I used to send all my patients for a cortisone injection in the hip before surgery, but now I'm backing off that a little bit and trying other options. You can use anti-inflammatories, ibuprofen, naproxen, Duexis, Vimovo. There's many different drugs you can use to help calm down the inflammation. But those drugs also have side effects. They can cause stomach irritation. They can cause kidney disease if you use it at a high dose for a long period of time, which is a much bigger problem than having an arthritic joint. Once you get into narcotic-based medications, you're dealing with a whole lot of consequences, from constipation to addiction, and it's just not a long-term solution for arthritis of any type. Glucosamine chondroitin sulfate, it sometimes works. We don't know why it works. It certainly doesn't build new cartilage. It may have an anti-inflammatory effect. I think it's a very low-risk drug. I don't think it has many side effects. So if it helps you, it helps you. And then visco supplementation injections such as Orthovis, Synvis, Euflexa, Hyligan, Suparts into the joint is something that is, once again, could potentially increase your infection risk because you're introducing a foreign substance into your hip joint before doing surgery. But I think it's still being teased out in the literature whether these are helpful or not. I don't do them, but some of my colleagues do. So hip replacement is basically the ultimate answer. Once you've exhausted all your non-operative and minimally invasive things that you want to do to try to help yourself with your hip arthritis, hip replacement is an excellent choice. It is one of the most successful procedures, not just in orthopedics, but of all of medicine. It has a 90+ success rate. We've been doing it for 70 years. It used to look a little bit like that. They look much different now. But it's one of the most successful things that we've done in orthopedics, and we will continue to do them. And we're getting better and better every year. So there's different types of hip replacement. There's the total hip arthroplasty, which we're talking about today. There's the hemiarthroplasty, where you replace half the hip. That's usually for hip fracture and for people who are more sedentary and they don't have a lot of demands on their hip. And there's a new procedure called hip resurfacing, which is falling out of a little bit of favor. It's very technically demanding, and it's not for everyone.
Why not?
Sometimes your femoral neck can break if you do a resurfacing. And a lot of people end up getting total hip replacements after they get their hips resurfaced in any case. So the idea of a hip resurfacing is to save more bone, but while you're dislocating the hip and resurfacing it, you can damage the femoral neck and then end up with a hip fracture some months later. And so that's a really bad complication of that. Some people have pretty good success, but it's nowhere near the success rate of a total hip replacement. And if we're finding our total hip replacements now are lasting 25 years and some are lasting longer, if you're in your 60s, what is the purpose of having a resurfacing? Because your hip replacement is likely going to outlive you. That's the goal. That's what we want to do. We want to do the surgery one time and never have to do it again.
So do you mind asking questions as you go along?
Oh, no, absolutely.
Okay,
You guys ask about it now.
So
It's casual.
On that point, I've been, at 2011, diagnosed with inflammation of the sacroiliac joint.
Mm-hmm.
Does that play into this scheme of things?
Only if you have hip arthritis as well. So if you have hip arthritis and SI joint arthritis, that's a bad combination because you have two stiff, non-pliable joints. Basically, it would increase your pain in your SI joint if your hip is stiff. Okay, if your hip is normal and you don't have any hip arthritis, then hip replacement is not a good option for you. For you, cortisone injections in the SI joint, physical therapy for the SI joint, ultrasound treatment with the physical therapist, things like that will help you. But that is a difficult problem. Ultimately, surgery could be an answer, but not hip replacement surgery.
That's why when I saw the invite, I saw hip replacement, and I don't think it's the hip thing, it's the sacroiliac joint.
You need to be properly diagnosed. You need to that's something, and you need a good surgeon to take a good look at you, all your x-rays, a thorough physical exam to make sure it is a SI joint versus a hip, because they're very confusing.
I'll finish up in just right now. That's the right side. Left side. Herniated disc, L4 and L5. Does that part, I would gather, the imbalance there because I'm struggling with the pain on either side.
Still two different
situations.
Yeah, two different situations. Both affecting the same area, and both can cause pain in the hip, but not necessarily hip pathology. But like I said before, you have to be diagnosed appropriately.
That's why.
How do you diagnose this?
A physical exam. I start everybody with a thorough physical exam. I mean, MRI can give you a lot of information, but I can definitely tell the difference between the SI joint problem, sciatica problem, what you're having, and hip arthritis. It takes 5 to 10 minutes to do.
Which is now the radiation on the left is radiating down in the leg where I'm getting total, it has its moments where it goes totally numb.
That sounds like a sciatica problem. But we can definitely help you with that. That's something we treat as well.
So if you're having hip issues, and I know I do, I've had the x-rays, I've been an orthopedic guy, will that exacerbate a sciatica issue or problem?
Absolutely.
And will this surgery kind of like either make that go away, or would you
Well,
then have to work
It all
on it?
depends. If you have a structural issue causing sciatica, if there is something actually pressing on the nerve in your back, hip replacement's not going to make that pressure go away. And it could be a disc, it could be a bone osteophyte complex in your back, but that's something that we'd have to look at with the MRI.
Yeah, okay, because I know I'm walking funnier these days, and I know it's, the sciatica seems to be...
Yeah, if you're walking with a limp, absolutely it's gonna
Yeah.
make your back problem worse.
Okay.
Unfortunately, we're not allowed to, we can have more than one problem at the same time. And that's just the reality of the world. It's unfortunate. So with surgical approaches for hip replacement, you see there's a myriad of approaches. There's the anterior approach, anterolateral, direct lateral, with the posterior lateral, which is the most commonly used approach in the United States. The one thing common to all these approaches is every single one of these approaches goes through a muscle body, or you have to release ligaments, or you have to release tendons. The approach that I do and that I teach is a direct anterior approach. The standard approach that 95% of the surgeons in the United States do is the posterior lateral approach, which I used to do and I started with. The drawbacks are they require you to be at the lateral position, which is it's difficult for us as surgeons and anesthesiologists to lay you like this for 2 hours to do the procedure. You end up with a 15-centimeter scar, which for me at this point is a gigantic incision. You dissect through muscle. You can cause bleeding. You can cause weakness. You have dangers to the sciatic nerve, inferior gluteal artery, which is a very large artery to stop bleeding once it starts, and that's why some people need blood transfusions after their hip replacement, which we don't do anymore. You can have limb length discrepancy because it's hard to judge the exact lengths of both limbs in the lateral position. And there's the dreaded posterior hip dislocation. Because you've gone through the posterior structures, you've released the muscles, there's a chance the hip can slip out of position. Okay, and this is what the incision looks like in the standard, and this is what's going on in 95% of the operating rooms in America. And they say once you're done with your posterior lateral hip replacement, you have to watch how you sit down. You have to get an elevated toilet seat. You can't sleep a certain way. You have to watch how you touch your shoes or tie your shoes. With the anterior approach that I do, I tell my patients you can do the splits in the PACU. I have no dislocation precautions. In fact, I cannot dislocate the hip myself once I put it in. So that is revolution. So my greatest energy is into educating our physical therapists, because our physical therapists come to the house or the patient goes to outpatient physical therapy. They say, oh, don't do this. Don't bend over to touch it. And I have to tell them, absolutely, they can do anything they want. There's no position restrictions whatsoever, because we didn't cut through any muscles, any tendons, or any ligaments.
What is this called?
Direct anterior hip replacement.
And is this how new?
Well, in America, it's been exploding over the last 5 to 10 years. It's been done in Europe for a very long time. So the way I do it, and this is one of my patients, we make a small 10-centimeter incision on the anterior aspect of your hip. Okay, and we it's very slick how we do it. The only thing we open is the fascia, and the fascia is the covering of the muscles. And once, with the help of our anesthesiologists who give us total muscle paralysis during the procedure, we can open the fascia, pull the muscle end block out of the way, the entire muscle. That's the tensor fascia lata muscle. The next muscle underneath would be the rectus femoris. We go through that fascia, we pull that out of the way. That leaves an unnamed fascia. Next, we cut through that very gently. We ligate one large artery, and that leaves the hip capsule in front of us. We make a capsulotomy, a cut, opening in the hip capsule. That's the only structure we cut through, and we repair that at the end. We're able to do the hip replacement with the use of a table, which helps us manipulate the hip. So what we do is we allow the table, the device that holds your leg, to bring the hip to us instead of us dissecting structures to get to the hip. And so when I take my retractors out of the hip, all the structures go like, bloop, they kind of just go right back over each other. I stitch the fascia, I stitch the skin, and that's it. 50 to 75% of my patients are going home the same day. And so this is what my incisions look like. And this is the hip going in.
Is that metal?
Yes. usually metal alloys, but they're all different types of hip replacements. Titanium alloys, metal alloys, stainless, and with a mix of stainless steel.
No, it's the same type of total hip replacement where a large piece of the metal goes into the femur, I guess.
Yes.
So you cut that all off.
Yeah. The arthritis is bye-bye. Goes in the garbage. There's no arthritis left.
Will it grow back? Will the arthritis
No,
grow
it
back?
will never grow back.
So if you're allergic to the metal, then what?
That is a great question. So there are certain hip replacement, and that is a devastating complication to find out that your patient has a metal allergy after you put it in. Because then there's only a few hip replacements out there that are hypoallergenic. Are you a metal allergy patient?
Yes.
So there, you need to be very careful about the surgeon that you choose and that he knows about metal allergies. And there are certain hip replacements that you can have that don't react to most people with metal allergies. And we can talk about that further. That's very common.
How do you know if you have a metal allergy?
You get tested, or usually you find out early in life with rings or earrings, or if you have a surgery where you have a metal implant, you find out that it's causing you a problem. And then usually you know that prior to getting a hip replacement, because usually people who need hip replacements are in their 50s and 60s or even older. So by now, you've had problems with metal before, earrings or rings or something like
What
that.
kind of problems? I've never had a problem. What
If you put a ring on and your finger swells up or the skin begins to flake, things like that. But yeah, that's something you really need to be on top of before having a hip replacement.
Didn't they
My
have to
ear is weak.
Yep, that's a metal allergy.
Yeah.
Didn't they have to recall some of the hip
Yes,
replacements?
Metal
because
on metal. It's been
metal
an
was getting
absolute-
into the body?
absolute
somehow?
disaster. I was lucky, I wasn't some type of genius. I just got lucky and I never
Weren't using it?
bought into the metal on metal. I just didn't.
Okay, so
just
that's
total
not
luck.
used anymore at all?
It is used. I'm not sure why people still use it because the complication rate is so high. They squeak. You get metallosis because the problem is you take a hard structure on a hard structure, metal on metal, it's going to create some debris, and that's what's happened.
Yeah,
And when you create these microscopic debris, your body's defense system, white blood cells come and eat it, and they leave residue. They, all the things they use to dissolve that metal dissolve your bone, and it's causes a big problem. And I revise a lot of those surgeries now. Some people have a full business of revising those surgeries.
So there's not a metal cup in the socket?
There is. So the device I use is metal in the stem, which goes down to the femur. Okay. Then either depending on your age, if you're 95, years old, we're going to use a metal ball on top with a polyethylene, and then the metal. Okay. If you're younger, someone your age, we would use a ceramic ball. I mean, you're young in my practice. You're young. We use a ceramic ball because ceramic on poly, there's less wear debris. It's gonna last a lot longer, but it's far more expensive.
So the ball is coated.
Yeah. So metal, ceramic, plastic, metal. So there's no metal on metal articulation.
Now, does Medicare give you a hard time on what procedure
I don't.
to
Yeah,
use?
I don't. I try not to even listen to what the insurance companies say. I do what's best for the patient, regardless. And if they slap my wrist, then they slap my wrist.
Well, I mean, that's an issue for people that are dependent on...
Oh yeah, not
covered
for
in
you.
surgery,
We
that's
make
what
sure
I
the
mean.
patient is. No, there's not going to give you a problem. They might give me a problem, but
Oh.
that's not your problem.
Is Medicaid one of the insurance plans that you,
We can work something out with that. I currently don't take Medicaid, but my partners take everything. So we can get you in, and if they need to operate on you, and I supervise because I do teach the approach, and we can work it out somehow. So this is the way we kind of do it. So this is the approach. This muscle right here, the tensor fascia lata, is the first muscle we encounter. We pull that laterally. The next muscle down is the rectus femoris. We push that medially, leaving a fascia here, which is unnamed. I was thinking about naming it the Henderson fascia, but people let me get away with that. We dissect carefully through that. We ligate the one large vessel, and then we are at the hip. Okay. We do not cut through any muscles. Okay. We do not release any ligaments. Okay. We do not release any tendons. So the chance of you dislocating my hip is the same chance of you dislocating your hip right now. Okay. You can walk with full power. My patients are off their crutches within a week to 10 days. I put Officer in Secaucus back to chasing bad guys in 3 weeks. My patients go back to work in 2 weeks, and like I said, 50 to 75% of my patients go home the same day.
And so you would need a rehab, because I know a lot of
Yeah, we
times
send them
people
right.
have
We
to go
start
to
rehab the next day. So
Oh, so you don't have to go to a rehab center?
no. You go
That's
home
what a lot
and
of people used to have to do.
yeah. So well, the average length of stay for hip replacement in the United States is 3.7 days, and 9 years ago it was 5.8 days. Okay, and then if you go back further, it used to be 2 weeks in the hospital. So now and insurance companies hated that.
Mhm.
Hospitals love that. So in 1,000 years from now, we're probably going to be able to wave a magic wand over someone's hip and it's going to be replaced. But as it stands right now, doing a hip replacement and getting you out of the hospital in 6 hours is the cutting edge, tip of the wave hip replacement in the
And
world.
you can go home and live fairly normally? You can't climb stairs.
You can do
You
everything.
can climb stairs.
You can
come
do
home
whatever
from
you-
the hospital and go up the stairs.
Absolutely. We wouldn't be able to send you home if you couldn't. Remember, we're not cutting any muscles, so the weakness that's associated with muscle dissection is gone. Dislocation precautions, watching how you move your leg, is gone. You get sore because I have your muscles stretched out for an hour and 15 minutes. That's how long it takes me to do that procedure. So when we release everything back, it's not like you just wake up pain-free. You'll feel the soreness of a severe muscle stretch or a muscle strain, but that goes away. So, the name of the procedure I do is called the Othello, anterior total hip equal leg length operation. So how do we make sure the limb lengths are equivalent? The easiest way to get yourself a lawsuit as a surgeon or have a dissatisfied patient is when a person comes out of a total hip replacement procedure and one limb is longer than the other. Nobody likes that because you have to put a shoe lift in, the person walks with a limp, or they just don't feel right. So when you're doing a posterior lateral approach, it's very difficult to make sure your limbs are the same exact length. With this procedure, how do we make sure that the limbs are equivalent every time? Well, we cheat. We use X-ray throughout the procedure. That's a low intensity, what we call fluoroscopy or CR fluoroscopy. We use it, we take a picture of the good hip, or even if it's not a good hip, your other hip during the procedure, and then I go back and look at the operative hip. And we make sure they match exactly, or up to, the human eye can't really detect up to 1.5 to 2 millimeters. But as close as the human eye can see, we get your limb lengths that close. This is what my incisions look like. This is what the device that I usually use looks like. This is the metal alloy stem, which goes down to the femur. We don't have the ball in this picture, but this is the polyethylene liner, which goes inside the metal. And there's one more piece, a ball of ceramic, which goes right on top here. I've been experimenting with some very new, very short boutique hips of late, and incisions are getting smaller and smaller. We're getting more minimally invasive. We're using smaller prostheses. Everything we're doing is we're trying to improve the experience for the patient and their outcomes. So everything's getting a little bit smaller. So with the Othello approach, you have smaller incisions, about 10 centimeters. There's no limping. Once again, remember there is no muscle cuts. Okay. Decreased postoperative pain, increased strength postoperatively. We're not cutting any muscles. You increase your strength. Less blood loss. Obviously, we're not cutting through muscles. They're not bleeding. Reduced risk of dislocation. In my hands, I've never had a hip dislocate since I started doing this procedure in 2010, and that's 450 procedures. Quicker rehab. You get to go home the same day. Faster return to activities. I put 0 restrictions on you after this hip replacement. If you want to run the marathon, we'll have a conversation, because just like I talked to you about the treads on the bottom of your sneaker, or the treads on your tire, if you start running marathons with my hip, the plastic is going to wear thin, just based upon the amount of revolutions. But if you want to run the marathon, we'll replace it again at some point, I guess. Faster return to activities and shorter hospital stays. Like I said, we're doing the majority of them outpatient. So what is the natural evolution of hip replacement and the anterior minimally invasive approach? As we talked about, outpatient total hip replacement will be the standard of care in the United States of America in the next few years, in my opinion. When I started talking about outpatient total hip replacement in 2011, I would go to meetings and I'd start telling my professors and my colleagues, hey, look, I'm sending these guys home. There's a 55-year-old, I did an anterior hip replacement, total hip replacement, I send them home. They said, yeah, Dr. Henderson, that's good. We know what you're doing. You're sending them to a rehab. You have a deal with the rehab that they take them from the hospital. I was like, no, I'm sending them home to eat ice cream with their kids in 6 hours. And I got literally laughed out of the room. And so, that happened twice. Third meeting I was going to in Florida, I was going back, I was like, look, you know, I'm doing these people outpatient, I think we really should look at it, maybe put them in the outpatient surgery centers. And they said, we know what you're doing, Dr. Henderson. Dr. Berger in Chicago has been doing it for years. I said, look, you guys can call me a liar, but now you have to call these people a liar. I flew 3 of my patients with me. And they came walking up the stage, and they said, we went home the same day, and it was like silence. So, 2013 or 14, I went to the largest orthopedic meeting, and guess what they're teaching? Oh, outpatient total hip replacement. Same day, home safe. I took a picture of this because 2 years before this, I was getting laughed, or 3 years before this, I was getting laughed out of the room, and now they're teaching it at the AAOS. I love that, by the way.
Sure.
It's very. So, like I was talking to you about, years ago, 9.1 days. Right now, it's still about 3.7 days. And the natural progression of hip replacement surgery and knee replacement surgery to a point. The reason we're not so successful with knee replacement surgery because total knee replacements hurt a lot. Hips we can get away with because the pain is not so severe. But I think it's, you know, and it benefits everyone. Nobody wants to stay in the hospital. Number one, that's where the germs live. If you're staying in the hospital, we're giving you more medicine, we're spending more money, so the insurance companies don't like it. So we can get you home faster, I think it's safer all around.
Why does a knee replacement hurt more? Is it more vascular? Is it
It's more invasive. We're cutting the bone in more places, we're doing more of a resection, it's more subcutaneous, it's not deep inside your body like the hip replacement.
Right, okay.
So how do I safely make hip replacements outpatient? 70-year-olds and under, and every 70-year-old is not the same. There are 70-year-olds who can beat me in a foot race, okay? And so I will take it case by case whether I can send you home or not. No ileus or hepatic disease, because if I do a hip replacement on you and you go home with an ileus, which means your bowels have stopped working, I'm not doing you any favors. No cardiac disease, obviously. We don't want you to have a heart attack. This is a stress on the body. No renal disease or coagulopathy. That means your blood doesn't clot so well. If I send you home with a fresh wound and you bleed all over the place or have a hematoma, that's not going to work very well. Obviously, no pulmonary diseases, delirium or dementia. Some people, when they're in the hospital, they're going to go big procedure, they get confused, we can't send those people home. And a BMI of 30 or under. I can't, you know, if you're large, it is very, very difficult to do this hip replacement outpatient. We can still do it, but we usually keep you in-house at least overnight.
BMI 30 is pretty selective.
It's not so selective, but I do the hip replacement on everybody, the same one. I'm just not going to be sending you home the same day if you're over 30. So I basically bring you in overnight.
Okay.
I take a look at you because your risk of complications and wound complications in particular are higher. So I just, you know, just for my own paranoia, whether it means, you know, whether it's meaningful or not, I bring you in so I can say hi to you in the morning and make sure you're okay.
I have a question.
Yeah.
I'm here for my partner who's been suffering for years. Was told 7 or 8 years ago she needed a hip replacement. She could barely walk around.
People do that all the time, by the way.
Is there a point by which it's too bad to
No.
do this procedure?
Absolutely not.
Okay.
So I love the person, and it sounds a little bit morbid, but I love the person who comes in and they are in devastating hip pain because I look like a hero.
I mean, she
At the-
basically not get out of bed anymore.
Right,
without a
and that's, you
huge
know,
pain.
if this is for hip replacement, then that's sad. She should definitely come in and get looked at.
Okay.
Yes, ma'am.
Can this procedure be used on somebody who breaks a hip?
Yes, and I do that. And I
Okay.
started doing that in 2012. And so I have completely changed my practice. I do not do, and the only time I do a posterior lateral or posterior hip replacement is if I'm doing a revision from another surgeon. And if there's already an incision and there's already a path and there's already scar tissue, okay, so I'm not going to make this any worse. I'm going to go through the same incision and use the same path for surgery. That's the only time I do that approach at this point. Otherwise, if you have a hip fracture or any other hip disease, I'm going to be going through this minimally invasive approach because when I do the posterior lateral approach now, I feel like I'm being super invasive. I feel like I'm butchering things that I should not be cutting through. You know, after you see, you know, once the mind is expanded by a new idea, it never regains its original dimensions. And you know that if you can get to the hip without causing any damage, you want to go that way every time. So I also have a standardized protocol, you know, to help with pain, to help with your pain post-operatively. I give all of these medications, and this is technical stuff. I do a lot of teaching for other surgeons. How do we take hip replacements to ambulatory surgery centers? How do we do same day? So I give them my protocol of how we do it. So this stuff is not really going to interest you. This is for the surgeons. I'm not sure if it'll do it on this computer, but this is a video. Yeah, it's probably not going to play. If we had an upgrade, I'd play you guys some of these videos of patients walking. These are people who have had outpatient total hip replacements, and they're walking literally 6 days out from surgery, but I don't think it'll let me do it. Unless anybody knows how to do it.
No, I think we might not have the.
That's okay. I'll have to get some videos to you guys so you can see. But these are my people who have had outpatient total hip replacements, and these are my real people.
Right here.
Questions?
Yes. Doctor, I fell 3 months ago,
Yes, ma'am.
and I thought my head go 2 ways.
Mm.
That's how much I fall on in my right hand side.
Mm.
And this time, I have no feeling,
Mm-hmm.
cold, right here,
Mm-hmm.
no feeling. So I went to the doctor, and he said to me, Elizabeth, if a feeling no come back to you for 3 months, so you have to live with them, or you go to the doctor, you know, to the hospital,
Mm-hmm.
get it over. But he
Sounds
says,
like you had a nerve injury.
So I don't know what is this. A little bit like I feel like when I touch my face, like 100 needle in there. You know?
Mm-hmm.
But
Paresthesias. So the good thing that you're telling me is that you actually started to feel some tingling.
A little bit.
Okay, that means
yeah.
that you did not have a complete nerve injury. That's called a neuropraxia. That
This is
takes
3 months ago now.
no, that's going to take much longer than 3 months. It takes a long time for that to recover, but that will likely recover.
Mm.
If you had no feeling at all, that means the nerve can be cut, and
No,
if the
I
nerve's
do
cut,
not- if I touch it, you know, I do another like you said, you know, like
I think you're going to have a numb face for a while, but I think it'll come back.
if I go to hospital because I do my teeth, you know, now I wait. I said, you know, make my teeth, fix my teeth, but now I wait. I said maybe go away and come back when feeling. But there's nothing wrong. I went to the dentist too, and he told me, Elizabeth, your teeth is fine. But I'm so scared, you know. If
Oh, I
start-
think you're going to be fine. It's just going to take some
Take
patience.
time.
Hmm. I see it all the time.
How
Absolutely.
about the pain?
Well, anti-inflammatory
my
medication.
back, my leg, like I said.
Everything's hurting, huh?
I'm 86 years old.
And
so-
you look good for 86.
Speaking of
I live
nerves,
with
do you
them,
cut
right?
through any nerves?
So, great question. There's a small nerve called the lateral femoral cutaneous nerve. Okay, and if you want to read about this approach, it's called the direct anterior approach for total hip replacement. So the lateral femoral cutaneous nerve is in the field. It's one of the first things we see before we get to the fascia. It lays on top of the fascia, and sometimes it's draped across the fascia right in our area of incision. So we can sweep a bunch of the nerve, and they're very small nerves, looks like little hairs. We can sweep a bunch of the nerves out of the way. That can cause some lateral thigh numbness, which usually goes away, or patients seem to forget about it. The worst case scenario in that case, if you cut right through the nerve and the nerve forms a little bulbous ball at the end of that, you can get a little painful spot. I haven't had that happen, but it's definitely a theoretical risk. But the numbness from sweeping the nerve out of the way absolutely can occur.
Dr. Henderson, you're not the only person who does this type of surgery.
In this area, there's one other surgeon in New Jersey who is doing outpatient anterior hip replacements somewhere down south. I know he's doing them. I just heard about him. He just started doing them now. And in your first 30, it's very hard. Once you're up in the 400s, it's it gets fairly routine. But people are learning. I'm teaching my partners. I design some of the technology, so I teach other surgeons, and I actually sell some of this technology to other surgeons. And when they want to learn how to use it, I'll fly out to wherever, to Oklahoma or California, and teach them how to do the procedure. So it's coming. And then there's Tyler Goldberg in Austin, Texas. There's Dr. Greenhow and Dr. Laux in Denver, Colorado. There's Joel Mata in California. And if you want to go overseas, there's Dr. Dora in Switzerland, and there's a bunch of Francois Laude in Paris is probably the what we consider the best guy in the world at the technique. But yeah, it's coming. But when I came to New York, so I was in Atlanta before, and we were doing outpatient total hip replacements, and I came to New York. I joined a practice that's based in New York, and I went to Beth Israel, and I said, hey, I'm doing outpatient total hip replacement. They said, slow down, what are you talking about? we can't do that here. And I was like, what do you mean? It's better for the patient? It's like, no, we're not. And then I talked to my partners who've been working in New York for a while, and they said, you're an absolute threat. How can you compete against somebody who's going to come in and say they're going to do an outpatient total hip replacement when their patients are staying in the hospital for 3.7 days?
Yeah.
They're not going to let you do this. You can forget it. And so they shut me down. So, you know, we took our procedure to New Jersey, and St. Barnabas has been happy enough for us to start an outpatient total hip replacement program. Potentially Morristown Hospital, I spoke with them yesterday, but, you know, and we're going to take it to ASCs.
In Livingston, St. Barnabas? Is that
St.
where-
Barnabas and Livingston, absolutely. They're
Hackensack is not doing it?
No, Hackensack is not doing it.
That's interesting.
There's a Dr. Hartspan.
That's the one I
Yeah, he
had
is.
been recommended to my son.
He's not doing the anterior. He's doing it posterior, and we've had a long talk
Okay.
about that. He was actually one of the guys who was giving the talk about the outpatient total hip replacements at that meeting. And with Dr. Hartspan's approach, great surgeon, okay,
Yeah.
absolute great surgeon. There's still dislocation precautions. You still have to watch how you cross your legs or sleep or stand up out of a chair or what have you.
So it's good, but not as good.
It's good, but there are risks, and you know, if you're as successful as Dr. Hartspan is, he's been in the same practice in the same area for a very long time. It would be very difficult for him to just change. You can't go to a weekend course in Las Vegas and learn how to do this approach.
Right,
I took time to go see Dr. Dora in Switzerland, Dr. Goldberg in Austin, Texas. I took 2 months off of practice to do 22 surgeries where I scrubbed in with these guys who have done thousands. And I learned, and there's very nuanced things in this surgery. So I took my time. And then for my first 30, well, my first 3 actually, one of the professors came and visited me like I go and visit people now.
Mhm.
And they basically said, that looks great, and took me through it, took all the fear out of me doing it
Mhm.
myself. And then, you know, but if you're a posterior lateral guy and you've done 2,000, 3,000 like Dr. Hartsman has, he's not going to take 2 months off of practice to go learn an anterior approach, or neither would I. I'll just keep on being successful.
Now, are you the only doctor that does this in your practice?
Yes, in my
Right.
practice. But one of the other guys, one of the younger guys, is trying to learn now, and he'll get it together. Yes, ma'am.
A year ago, Dr. Pelosis in Wayne, he told me that he had an MRI, and then he said I have a lot of arthritis on my hip.
Mm-hmm.
Now, I'm wondering, I belong to Silver Sneakers, which is, heard of that?
It's
a
a
program for exercise.
Mhm.
Is that all right for me to do, or am I hurting it more?
I don't. Well, Laura, is it hurting you when you're doing the exercise?
No.
I would continue exercise, absolutely, whether you have hip arthritis or not. And you will know at some point enough is enough, and then you'll call an expert, and you'll go see an expert, and you'll get treated. But don't stop doing the things you like to do.
Okay.
Dr. Ramirez, one more thing.
Yes, ma'am.
In the morning, every morning when I get up, like 5 o'clock or 6 o'clock, I get up in the bed, right? In a second, when I go to my kitchen, I have to hold on to something because I feel something, no, just a second, I drop something, I have no feeling, a second in my hands
Mm-hmm.
or my legs, and that just come back to me.
Mm-hmm.
But I don't know, I told my doctor about that, and he said he doesn't know what's that pain, he cannot treat me for that, I don't know. She said, I don't know.
It also sounds like a
I
nerve
get up
issue.
in the morning, I woke, I have to hold something to them because a second I have no feeling in my legs and my hands.
That is a nerve issue.
It's a nerve.
Mhm. That would be something that your primary care doctor, if they don't know what's going on with you like that,
Yeah.
if
But
it's
she
troubling
should
you,
know.
they should refer you to a neurologist.
But yeah, she told me, you know, but I need to go to the doctor.
I
I need that, but I have to, because, you know,
I would
can
go see
drop
somebody
my cup of
about that.
coffee, a second,
yeah.
I feel that I drop it if I don't put it down.
Mm-hmm. That's a nerve issue, man.
It's a,
Absolutely.
and really what this can happen,
Well, I mean, you'd have to see a neurologist or nerve doctor
Yeah.
about that.
oh,
You know.
okay, doctor.
No problem. You're
I
welcome.
have